mindsets to reduce healthcare disparities and improve health equity using implementation science. These are certainly my own mindsets that I have curated here for you, and they are not mine alone. You know, we are all of our thoughts are such a formation of those who have influenced us. So as we go, there's a lot of people credited, you know, for conversations we've had, or pieces that they've written, or presentations they've done, or books they've written that have kind of it formed that mindset. So a mindset is not a prescription. It's simply a way of viewing the world and thinking about something. So I imagine we are all here with a wide variety of experiences with implementation or implementation science. Maybe some of you are newer and some of you are very expert. And some of you are on that spectrum for thinking about equitable delivery of healthcare and or disparities, unjust differences. So wherever you are, I hope this is helpful. And there is one kind of message that I want to prepare, because I find when we talk about equity and implementation, it can be really overwhelming. So let me show you a written version while I read it. Okay. Here we go. I am kind of blocking this, sorry. For equitable, just, and sovereign implementation of good care, we must embrace the complexity. Both of the, you know, implementing any treatment is complex on its own, and doing it, making sure everyone's receiving it in an equitable way for their needs is even more complex. So we must embrace that complexity and realize that these are long-term, career-long, lifelong endeavors. And so it is complex. It is not an easy fix. And so something that I find kind of combats the overwhelm is to show up to discussions like these or presentations like these and just think for yourself, to be really selfish with the material for you as you hear it, and think what one or two ideas resonate with you personally, not with the person next door, not with me, but with you. What resonates with you, and then what's feasible as one next step in your own journey. So that's just something I'll offer to you today, whether you find that helpful or not. My hope is that it is helpful. We got present. We did that. A few disclosures. Although I work for lots of different places, I'm not here representing them today, the United States government, the University of Arkansas, and nor my paid consultation with ViiV Healthcare in HIV prevention. Just here as Eva Woodward. So the basis of inequitable care is that sometimes people who need quality care are actually the least likely to receive it. This is an idea known as the inverse care law that was documented in 1971 in a publication. And that I think anyone would describe is unfair at the minimum. But there is also other levels to it. Those kinds of disparities in healthcare inhibit health equity and justice. So here's just some kind of leveling terms to share with you when I'm talking about terms, what I'm meaning. There are health differences. So those are differences in a health outcome between two groups based on a specific characteristic. So for example, the presence of tennis elbow, health problem, one that can be inhibiting if you have played tennis, is more likely to occur among people who play tennis than people who play soccer. So that's a difference based on what activity they're engaging in. And a health or a healthcare disparity is not necessarily only a health difference. So not all health differences are health disparities. Health disparities are concerned with social injustice, in which one group is experiencing a worse health outcome because of some injustice, marginalization, oppression, or disadvantage. And health equity is a hopeful aim. It's the principle underlying a commitment to reduce and ultimately eliminate disparities in health. and its determinants, including social determinants of health. We're officially having our first time when I'm blocking your words. And so hopefully that my verbals are conveying the message. So, you know, a healthcare disparity or health disparity makes it difficult, if not impossible, to achieve health equity. Here is just a quick breakdown, a little bit more about healthcare disparities. So those are unjust differences between groups, not due to patient choice. It's not what patients would prefer, in either their access to an intervention or a program or a screening or a pill or a practice or a policy. They don't have equitable access to it, or they don't have equitable receipt of it. Once they can access it, then they are not as likely to actually get it once it is possible. And then if it's being delivered, there's a lower quality of its care. And it's not delivered consistent with clinical guidelines, for example, or what is best standard practice is what would be high fidelity. People are not receiving it at high quality. Or they experience disparities in then the outcomes of interventions. Let's say you have a treatment, a program, a practice, a pill, a policy, and it is then delivered to many people, many groups, a lot of diverse patient characteristics, and you find it actually isn't that helpful to a big population of people that are similar in some way. That would be a healthcare disparity in the outcomes. And importantly, one group that is having worse results experiences that societal disadvantage, marginalization, and or oppression. So that's what a healthcare disparity is. Now, let me ask you, multiple choice question. Get ready for your chat. Get your chat fingers ready. Thinking about your own field. Okay, in my field, I am aware of healthcare disparities in A, access to interventions. That's a real problem you're aware of. Receipt, B is receipt of interventions. They're not receiving it once they do have alleged access with insurance or they're in the system. C, quality of interventions. D, the outcomes of the interventions. E, all of the above. Or F, I am not sure yet. I'm on one screen here. Let me see. Okay. Yikes, we got a lot of E's. Okay. that is not surprising. Okay. Interesting. Okay. So you all in your particular field, whether it's infectious disease or mental health, or pediatric care, or certain policy intervention, you're knowing that there's inequitable disparities in access to those things. Then when they actually get into a system or have on paper access, they're not receiving it. And then it's not with high quality compared to other people. And then their health isn't as good even when they do get it. Okay, that means that there is a whole spectrum of places to intervene and do something about. There's work to be done. You will be employed. Okay, here we go. So let's jump into what we do about this. Remember, these are my thoughts about what we do about this, not the end all be all, but hopefully takes you somewhere on a journey. So I'm going to share 6 mindsets. This is mindset number 1. And I try to start with these mindsets, how I think about them in from beginning to end of an implementation effort or a research initiative. So we start kind of with higher level and get more granular, kind of. They're all kind of foundational, but that's sort of the order we're going in. Mindset number 1, think about where on the continuum of research phases your study or your work or your effort lies regarding two principles: disparities research and implementation problems. And then match where the science is to a suitable study design. So let me show you a visual. What's helpful is that actually the paradigms of implementation science and healthcare disparities research follow similar steps, which are implementation at the top is what you're seeing, healthcare disparities at the bottom. The steps are basically the same, which are detect a problem, understand why it exists, and then reduce gaps. So in implementation, you want to detect a research to practice gap. There's something we know works out there. Thinking about some of the people I can see on the screen, my limited screen, I'm thinking about lethal means safety discussions, about lethal means that people might use to kill themselves in healthcare settings. That's a very important conversation to have with certain segments of the population who are screening positive for those things. And yet, how often is that occurring? Is it frequently enough? Probably not. And so there's probably some serious research to practice gaps there. There's an implementation problem. And if that's detected, good. You don't need to do that work again. You can move to understanding why that gap exists. If that is understood and understood among everyone, then you can use implementation strategies to reduce that gap and evaluate how that goes, probably through continuous cycles of repeated implementation or quality improvement. And so at the bottom, if you then think about, because remember, these are complex, you've got all that at the top, and then you've got layered thinking about the disparities also in your work. So then you want to think about it in the same paradigms. Has there been a detection of a differential and unjust difference in access, receipt, quality, or outcomes of lethal means safety planning or safety counseling? And if there has not been, then that's what you should do. If there has been a disparity, you find out that one group of people at the hospitals that are higher resourced or in wealthy neighborhoods, they're getting a lot of lethal means safety counseling. But hospitals and healthcare systems in low-income neighborhoods or people with patient populations that have lower insurance levels, they're not getting it that frequently. That's a sign that there is something going on, likely a healthcare disparity, and you would then want to understand it. So then your science would be more a type of formative evaluation or a diagnostic assessment, probably mixed methods to understand why that is for those places. And then once there is some understanding, you then want to design either interventions or implementation strategies to reduce that gap. And so for those of you who are very implementation science savvy, I think about this almost as like a different type of hybrid design. Actually, it's complicated because it could be like there could be triple aims in a hybrid, in which you might be detecting a problem in one part of the study, but actually already working to understand it or reduce it with another aim. So it does require thought, and it might also require designs or aims coming together in a way that's not the most common yet. What's fortunate is you have some guides out there. So there are study designs adapted to healthcare disparities in implementation science. My colleagues and I published this in Medical Care in 2017. And by the way, I will be putting a lot of resources up here. So you might be in Screenshot Central. Just get ready if you're one of those individuals who likes to do that. So here's an example of a decision tree from that paper that we made, and you don't need to take it totally all in. It's there for you, free and accessible online. But it's essentially a decision tree for what type of study design and implementation and or healthcare disparities might be a good fit. And it's quite simplified. Okay, is there a disparity? Yes or no? Yes, there is. Is there an evidence-based clinical intervention? You could think of this also as a program or practice for my problem. No. Okay, you should develop that and test that. But if there is, yes, well, is there evidence for clinical intervention among a vulnerable group of interest? Basically, do we have an intervention that we know is going to work for the people experiencing disparities? Yes, it is. And so then it goes on and you end up with suggestions here in bold. Okay, you should probably do a formative evaluation, or you could do a hybrid one here. and so on and so forth. If you're at the reducing phase, there's lots of options. Even though this language is now outdated, referring to groups as vulnerable, the thoughts around what study design works when still stand and can be useful. So that's figure 1 in that paper. So there's existing suggestions for how to kind of guide your thinking. But usually you'll be doing 2 things in one effort or study. Okay, mindset number 2. Giving everyone the same thing is not equitable. So giving everyone the same intervention or the same implementation strategy is not equitable. This is a visual I use a lot from the Robert Wood Johnson Foundation. We squeak aside so we can see our little cyclist. At the top, we have 4 people with the same size bike, and that is equality. There's a person who uses a wheelchair who can't even get on the bike. There's a very tall person that is using the bike but looks very uncomfortable, is hunched over. One person is using the bike comfortably, and then there's a child that can't even reach the pedals of the bike. Equity is at the bottom, where the bikes are different based on their needs. The person using a wheelchair has a bike that is outfitted with them for hand pedaling, and they now can ride like their friends and family members. The tall person has a taller bike, and they're more comfortable. The medium person just kept their medium bike, and the child has a smaller bike, and now everyone can ride. And note, what's interesting is also that the person who kept the same size bike between 2 pictures, nothing had to be taken away from that person in order for everyone else to get what they needed. It's an inherent problematic place that our minds can go is, well, if things are going to get better for other people, that means they'll be taken away from me. You can keep your bike. We can keep our bikes. Other people can have the bikes they need. We're going to be okay. So the bottom image is more ideal, where your interventions are either going to be adapted. For example, some of the work I'm currently doing in suicide prevention or using safety planning intervention. Right now, I have a community academic partnership between my team and rural veterans in Arkansas, and we are adapting that intervention to be delivered peer-to-peer in communities outside of hospital settings, because in many rural places, which is most of our state, there are not enough healthcare providers to go around. And so and yet we have an effective intervention that could help reduce suicide risk for people at moderate risk. And so the question before we even start with implementation is, should we do this exactly the same way in a hospital setting with trained mental health professionals or trained medical professionals? And we are wise enough to say, probably not. We should probably modify it first. And so that's what we're doing, because it's changing settings, and a whole different group of people will be delivering it in a different setting. This is true also for implementation strategies. Giving everybody the same implementation strategy and expecting it to have the same outcomes, it probably won't. So you'll need to plan in a way to tailor or adapt from the outset or as you go. There is existing guidance on how to adapt interventions to be better fits to implement, which is great. We don't have to make that up. So I just put two examples here on the left, a paper led by Dr. Wingood that's drawn from the HIV world. And in fact, there's a lovely video overview on this great series. This is a 2-in-1 for you. It's to tell you about this video series on YouTube that's hosted by, that Rachel Shelton leads at Columbia, the Irving Institute, which is a whole video series on implementation science and health and equity. And Dr. Wingood presents as one of those free. You can watch it. And then there's a great publication by Dr. Kabasa and Bauman on cultural adaptations of mental health treatments. So there's ways to do guidance to do this. And sometimes what you need is just to know that it's going to change, and you just know you need to document what's going to happen. That's a good option too. Or maybe you're in the middle of something, you didn't adapt it, and you're like, uh-oh, well, you could still just document what changes over time naturally, because that happens. So there are existing ways to document those changes to implementation plans or strategies that may differ for different groups. So a great tool for tracking strategies is on the left. That it's actually like not the major point of this paper, but there's a wonderful tracking tool. And I see we have our own, Dr. Bates is the senior author there, led by Brittany Rudd, that there's a supplemental file in that paper on the left that is an Excel spreadsheet, and I've used it for some of my work, and it's great for just tracking the strategies that were used according to the ERIC framework. And then on the right is a great tool for tracking when strategies are adapted, by who and why and when, which is FRAME-IS, led by my colleague out of the Behavioral Health Query BA, Dr. Chris Miller. So if you can't adapt it, at least track what is changing and why. Okay, mindset number 3, engaging end users affected by the health problem is gold standard in health disparities research and probably should be in implementation science too. So end users, you all have lots of different end users. Could you put in the chat who end users are in your field or your settings? So these are the people affected by the health problem. Just so I have a sense of kind of who we've got. Could you put in the chat who your end users are in some of your settings? Okay, we've got people in primary care, opioid use disorder. We've got a lot of pediatric involvement and their caregivers. We have veterans. Okay, people living with certain conditions such as HIV, cancers, diabetes, etc. Okay, so this could be, people in a healthcare setting. It could be people in schools. It could be people in criminal justice settings, whoever your end users are. So why? Well, preliminary studies suggest that engaging end users in implementation does at least 4 things. This is preliminary, this work, but it is out there. It can lead to a better intervention fit for the group experiencing the health issues. Second, it can lead to systems redesign that's more patient-centered if you're getting that involved with your implementation strategies and quality improvement, if an entire kind of system is being redesigned. And it can lead to a greater use of effective healthcare interventions in community settings. So actually adoption is higher when you're involving the end user. And ultimately, what we all hope for, the end goal, is it improves people's health behaviors, make healthier choices and healthier actions, and have better health overall in outcomes. And these are 3 great citations that either talk about that work or showcase it in some way. So clearly we have some preliminary evidence to suggest it is equally as important in implementation. And then people from communities that are experience a lot of oppression and colonization are saying that themselves. This is to showcase the United States Indigenous Data Network. Excuse me, I need to get out of it. I'm just totally covering it up. Okay, so because this is a quote from an Indigenous person in the United States that says, information, data, and research about our peoples collected about us, with us, or by us belong to us and must be cared for by us. This is a strong sentiment and movement within American Indian and other Indigenous people in the United States right now, especially this resource at usindigenousdata.com. However, it can be true of other groups, because groups of people have been caring for themselves for generations amidst incredible hardships, whether it's a certain religious enclave that has experienced a lot of discrimination and oppression, or whether it's entire groups of people that were forcibly relocated into this country. They have still been caring for themselves amidst very difficult societal conditions. And so they can and must care for the research in their own communities. It's possible. It's important. And in fact, this is one element where some of my current work comes in. So my team out of Little Rock, we are developing tools to teach healthcare employees how to engage people who have been marginalized in implementation activities. These tools we have a beta version currently, and a bunch of people just user tested them and told us everything that was wrong with them. So now we are working to continue to hone them, but it's a set of tools to help implementers figure out how to engage people from marginalized groups in implementation. So this is our protocol paper. And we are doing this among suicide prevention in rural areas, but the tools are developed to be used across health conditions and populations. And there might need to still be some tailoring, I'm sure, but the basics will be there. Okay, our next mindset. Think upstream about what is causing inequities or disparities. So you want to think upstream. You're thinking higher than individual level behavior, whether people are smoking or not, who they're having sex with or not. That is important. It's in the equation. But when you're thinking about health inequities, you want to think bigger. You want to think broader. Many of the disparities we see in current US reports are caused by structural and societal damage. So that's where we should focus our efforts, which is hard. So people like myself as psychologists, we're trained to focus at a very level of people's thoughts, emotions, behaviors. So here's a visual. It's blurry, but it still works. This is one of the original visuals of social determinants of health, where you see people in the middle and they have their own personal characteristics. And then outside them, there's some individual lifestyle factors. Again, who are they having sex with? What are they eating? What kind of things they're doing with their time? And then outside of them, they're nested in social and community networks. And now we're starting to think a little more broadly. You know, where are they working, living, and playing? Where are we working, living, and playing? And outside of that, what are the conditions where affecting those networks? What's the unemployment rate? What's our access to water and clean sanitation? There are places in this country where people do not have access to clean drinking water. What's the agricultural and food production? Is there a lot of local food grown and then eaten there? Is that possible? What are kind of the education levels and the work environments overall? Are there good labor laws and other living conditions? Like, for example, in Arkansas, we are one of the only states with absolutely no rights for renters. There's no standard of living for you. It was amazing when I moved here from New England, looking at rental properties, and they were not livable. And I was really surprised. And then I found out there's no laws to make that a requirement. Nobody needs smoke detectors. Nobody needs to worry about black mold. That there's no policy making that a thing. You just have to rely on people being good. So then there's a lot of issues around unstable, unsafe, unhealthy housing that then leads to a lot of health problems. And all of us have general socioeconomic, cultural, and environmental conditions that are happening, like federal policies or climate change, for example, or a pandemic. And so here's 4 ways to bring that in to implementation science, that mindset. So when you're thinking upstream about what's causing inequities or disparities, one suggestion is to partner outside health sectors to implement, or whatever sector you're working in. Think about the structures. Structures are linkages between places that uphold disparate care and can also be part of the solution. And so thinking about outside your own sector, is it you need to partner with education systems or criminal justice systems or some other system to implement for good equitable care? A second idea is to use system science, agent-based modeling approaches to capture all the cause and effect at those multiple levels. There's a great paper on this that's cited here, led by Dr. McNulty, that has a couple of good case studies of how they have done that. That's not something I have been able to try myself yet, but it's on the docket. Design research questions collect your data, analyze it, and interpret it using implementation science frameworks that account for upstream factors. There are some increasingly up there. CFR 2.0, it's not officially live online, or it wasn't as of 3 weeks ago. Can someone please check that out and put that in the chat? CFR 2.0 being revised has a much broader level of upstream factors, and yet is still rather broad. And the only one that's more specific is one I adapted with colleagues called the Health Equity Implementation Framework, which is cited in reference 3. So making sure the frameworks you're using to even design your questions are going to start to ask about these upstream factors, because if you don't go looking for it, you probably won't find it. And a fourth idea is that in your models, your logic models of how you think about things, and then the analyses you set up, is that you should link social determinants of health and other upstream factors to moderators of those health outcomes or those mechanisms of change. So those are some actionable ways to think upstream and to bring that into our work. Okay, fifth mindset. Measure then if you're moving toward equity and justice. So you want to actually say, is anything happening? Am I getting there? I want to measure the progress or lack thereof, or the harm. Hopefully some of the other things listed before have prevented harm, but it absolutely happens that when implementation efforts occur, we do more harm to certain groups, and that's our responsibility. So here are some good frameworks: measuring how implementation has affected equity outcomes by assessing concepts from these frameworks. These are not all the end all be all. If you already have a framework for evaluating things you like, you might then just start to think about it with an equity lens, even considering some of these mindsets. Like, are we assessing anything upstream or a moderator that might kind of be a mechanism of change between something upstream and the outcome we're interested in? It could be simpler than that. But if you want to draw from thinkers in the field that have already put a lot of thought and effort and work, there's 2 great frameworks that I have here, 3 readings you could look to. One is led by Dr. Rachel Shelton, which is an extension of REAIM around enhancing sustainability, and it is such a gem. They have such nice tables and examples of how you might have an equity lens on some of those REAIM concepts. And then a paper, I could not fit 3 screenshots on this page. So Dr. Bauman and Kabasa, they have a reframing paper from 2020 that has some ideas about how to change kind of some more pilot outcomes, feasibility, acceptability, appropriateness with an equity lens. And then I am standing over the conceptual framework of equity-focused implementation research for health programs by Dr. Aslava Schmalbeck. Okay, this paper has a lot in it, including a lot that's not about frameworks for measuring outcomes. So I put a little note for you to see table 3. That's where it's a good paper overall and captures things I've already talked about, but table 3 is where you're going to find some nice examples of concepts you could incorporate into your work to measure if it's getting there. Mindset number 6, here we go. We're at the end, and yet this is still foundational, okay? Acknowledge and plan for uneven power, privilege, and oppression of yourself, your team, and the communities you work for. So what do I mean by that? Each of us carries certain societal power. Each of us carries experiences of being societally dominated or oppressed. And it's not static. When I am with another group of women, I identify as a woman. When I'm with another group of women, that power can be more equalized. And when I'm in a group of people who are more male presenting or identify as men, especially if I'm more in the minority, then I feel and am more dominated in those settings. And so again, it's not static. It depends on who you're with. So every project you have will be different. The people on your team are different. The communities you're working for might be different. And so it is so important to consider the social positions, the lived experience we are all bringing to the table. So let me show you a couple of visuals and then some ideas about how I do this in my work. This is something I believe in, but something a great colleague who spoke at Penn in a different group 3 weeks ago, maybe, Dr. Corey Bradley has put more words to. Our process of inquiry, our entire process of trying to know things in science and the way we produce knowledge is influenced by our lived experience and the systems in place by those who came before us, and thus our and their biases. That's just what is. We are all carrying around our own lived experience. We are all carrying around biases towards other groups of people. In case you are not at all familiar, there is a ton of work, ton of work by a lot of social psychologists, sociologists, documenting that we all have a lot of bias against other people who are not like us, or even like us, actually, that can be internalized, whether that's based on the color of your skin, whether that's based on your weight, whether that's based on your gender. We all have a lot of bias going on. And the most important thing first is to be aware of it. So even thinking, I just drew some 5 little squares of my own thinking of the process of inquiry we have. Like, what are the questions that get asked and the problems that are focused on? And then what are the solutions that are proposed to fix those? And then what implementation methods, theories, strategies, data analysis do we do to evaluate that? And what do we think the mechanisms of change are? And then what outcomes occur? Everything in that, and probably stuff I didn't include in a square, is affected, is informed by our lived experience and the biases of ourselves and the people who came before us. So it is important to be aware of those in our teams as we're going forward. And in fact, if you did one thing differently, well, we're all on our own journeys. We're all on our own journeys. I'm going to stop myself. This is not prescriptive. I see this as very foundational. Okay, here's some examples of how. Making sure you self-reflect on your own lived experience. This is you. If you want to Google something about identity inventories, or probably something about reflecting on internal bias, there's a lot out there. There's a lot out there, and just use them as tools. Again, that these do not have to be highly prescriptive and diagnostic. But you can see here, this is from the University of Michigan, that there's a circle around the outside with different categories saying, okay, think about your own religious or spiritual affiliation, your race, your ethnic group, your socioeconomic economic status, and so on, your physical ability level, what your first language was, and then start to think about the identities you think about most often. Spoiler alert, they're going to be the ones that are more marginalized. Think about the identities you think about the least option. Spoiler alert, they will be the ones in which you hold the most power, that you don't have to think about. And then so on and so forth. But this is a pretty simple exercise you and people on your team can be doing. And then it starts to generate discussions about how does where we come from and how we see ourselves affect how we're doing this work with school-aged children in primary care. In this system, in this city, how does that affect? How's that changing things? A few other broader suggestions are just that there's many ways to critically self-reflect. You can build it in so many ways. So if you take a look at the right, you can do it privately by yourself, because this can be a very personal experience. You can do it with a peer. You can do it in small groups, or you can do it with someone who's a role model, a supervisor, a mentor. And then on the left, I have bulleted lots of different ways that I have engaged in critical self-reflection, and I know other people have as well. There are formal self-assessments, like the one I just showed you, and way more involved ones as well. You could just simply digest readings, blog posts, or infographics out there on thinking about your own identities, or maybe bias on a particular topic. You can get consultation from someone who might be more advanced in an area. You could do reflective writing. very important for me. You can have some culturally immersive experiences. Those are experiences where maybe you, your team, actually immerse yourselves without being voyeurs and, you know, really creeping on people, to be immersed in some of the cultural elements of the communities you're working for. Even if they're communities you come from, it is very likely that at this point in your life, if you're here in the Zoom room, you have earned yourself or worked yourself into some different circles. And with that, our mindset even shifts. And so it's important, even if it's a community you come from, to be reminded of the daily lived experience. So culturally immersive experiences are really helpful. Or maybe there's some types of interactions, whether it's intervention delivery or some type of implementation coaching, something you want to see and be given feedback on, that you can do audio and videotaping and get high quality feedback from someone you trust. Lots of ways to critically self-reflect on our experiences and biases. Oh my goodness, we've talked about a lot. I want to remind you, for equitable, just, and sovereign implementation of good care, we must embrace how complex it is and realize that these are long-term, career-long, lifelong endeavors. I'm just going to give 30 seconds of silence now, just to ask you to reflect on, you know, a lot that I just shared, very big picture. What are one or two ideas that resonate with you? And what's feasible for you as one next step in your own journey? And I'll just be quiet here for a minute and jot my own thoughts down about that. Okay, kind of wrap up any quick writing or quick notations. I'll be interested to see. We're here. If any of this just totally overwhelmed you, this is a really good place to start. If you need a place to start, these authors suggest 4 steps for pre-implementation. This would be before you're implementing something, led by Andrew Kirchhoff, called Addressing Health Disparities Through Implementation Science, a Need to Integrate Inequity Ones from the Outset. There's like 10 papers right now basically titled the same thing. So I'm just trying to decode this, that this is more about, there's 4 really nice steps about the pre-implementation phase to get you started, if that's where you are at. Thank you so much for your attention. Let's continue the conversation here and online. I'm going to spend the day with many of you. Stop sharing. I can do this.
Thank you so much, Dr. Woodward. That was an incredible talk, and we're all giving you a huge round of applause. You raised some really, really important points that we all need to be considering in our work at the intersection of implementation science and health equity. And we're so lucky to have you here as a senior scholar, and that you'll be spending some time with us in one-on-one meetings this morning. So we're so grateful to you for your time. I want to invite folks who have questions to either use the raise hand function and come off mute and ask your question verbally, and or to put it in the chat, so that we might spend a few minutes engaging in back and forth discussion with Dr. Woodward. I have a question, so I'll start us off while people get ready to, actually, I would rather hear from Katie and Rebecca. So Katie, do you want to ask the first question?
Thank you so much. That was a really wonderful and thought-provoking talk. One of the beginning and the end points in terms of that you made in terms of for more equitable, just, sovereign implementation of good care. The idea of sovereign is new to me, especially in an implementation context. And I was wondering if you could talk through that concept a little bit more with us.
I am so glad you are a sharpshooter, because I myself was like, I'm not totally doing this justice here, but I at least have to acknowledge it. So you noted something that I just was for space leaving out. So sovereign, means people have autonomy and control, and they are autonomous. And the whole idea of that there cannot be equity without sovereignty, without people having autonomy, control over the care they get, how data is collected on them. And one of the groups pursuing this the most intensely that I am aware of, which doesn't mean it is all of reality, is the US Indigenous Data Sovereignty Network. So a lot of American Indian peoples and tribes are really doing some things to, I shouldn't say regain sovereignty, because sovereignty is not gifted. It is an inherent right that we each have to data collected about us, to our blood, our cells, our own mental health thoughts and thinking. And so, for example, a lot of different tribal communities in the US have implemented their own IRBs within tribal councils, or perhaps have said, no one can do research on us, including the census, unless those methods are approved. You come to our local tribal councils and we help you decide how this is going to happen, even more to where there's less dependency on others to do research on our people, to where we train our own people to do that. Someone who writes and talks a lot about this is Dr. Desi Rodriguez Lone Bear. Let me put in the, no, that's wrong. Hold on, let me put in the chat her Twitter handle, which is @Native4Data. And anyway, she's just one person, but is one person who articulates a lot of these ideas. And so it's something I've been thinking a lot more about, that, it would, I think I've dreamed up an idea that healthcare could be more equitable and implementation could be more equitable easier. And I think that that's not true. That's false. And so the idea of sovereignty, of people having more autonomy over, the problems that are investigated, what happens to them, what data collected about them. And wouldn't it be wonderful? I mean, all of us here have our own lived expertise. Wouldn't it be great if we were working for our own communities? And what would it be like to have a lot more of the communities living? I'm talking about the US, but if you're working globally, wouldn't it be great if those individuals were worked up into the workforce, our workforce, and designing this work themselves?
Thanks, Dr. Woodward. I think we have time for one more. So Rebecca.
Thanks. Hi, so I'm Dr. Rebecca Clark, and I do research on birth outcomes and equity in birth outcomes. And I'm really interested in asking your thoughts about social determinants of health, because I'll be honest with you, I think it's a red herring. I think the issue is racism in its many forms. And so I think that social determinants of health actually distracts from that. And it's not that they aren't real, but I guess, so what I think, you can be Black and you can have a PhD, be a multimillionaire, a billionaire, you can have, a postdoc,
Right?
you can be an Olympic athlete, and you are still more likely to have poor birth outcomes, right? So I think that I see a lot of focus on social determinants of health. And I feel like, at least in this space, it is actually something of a distractor from what's really the underlying issue. I don't feel like I've seen other people articulate that. And I think maybe, maybe it's different, in other spaces, other issues, but I would love to hear your thoughts about that. And if you've, how that sits with you. And
thank you for studying birth outcomes. Nothing as important as the generation coming along. I don't think I have seen anything super formalized from my slice of the world also onto that point. And I don't disagree with your point, and I don't think that many people who study and know the science on that would disagree either. One interesting idea is to think about potentially social determinants of health, like almost being your like high level moderators. And because you ultimately are going to, I mean, this is science, you ultimately have to have some way to measure then that racism happening within social working and living conditions.
yeah.
And so maybe that's some way you can embed it, is, using state level measures around discrimination, or how equitable, anti-racist or racist certain policies are in your setting, like maybe at the healthcare setting, for example. Or maybe even people's just perceived and expected discrimination, racial discrimination, and how that relates to birth outcomes or implementation. I don't know all your specifics, but
Yeah.
the spitballing, like that makes sense to me, what you're saying.
Yeah.
And so if it's not out there, I haven't seen it formalized in a way that I could suggest something to you to like for further reading. And, as you continue to show up in those spaces, I'm sure you'll find like-minded people, or maybe you will produce that.
Maybe I will, because it keeps on bothering me and I haven't found an answer to it yet, but I really appreciate you taking some time to think about it and answer. Thank you.
Oh, yeah.
Thank you, Dr. Clark, for asking that very important question. I am going to wrap us up because we are a minute past the hour. This was incredible. The engagement was incredible, and we're so grateful to you. So thank you, Dr. Woodward, and we'll be chatting with you in a bit.
Okay. Bye, y'all. Take care.
Bye.